All right, let's get going then. So good morning, good afternoon, and good evening, everyone. Welcome to the second installment of the Global Health webinar series. We greatly appreciate everyone taking the time to join us today, and we hope that today's presentation will provide you with new ideas and information for developing EIM in your respective countries. We are now recording this webinar so that we can share this information with EIM Global Health Network Center members who are not able to join us today. The plan for this morning is to have approximately a 30-minute presentation followed by time for questions and answers. At the bottom of your Zoom window is an icon for chatting. Please feel free to write any questions you have there or to save them for the end of the webinar, and we will do our best to get to them all. So now on to the presentation itself. Our speaker today is Dr. Jonathan Fowles from EIM Canada. As you can see from the screen, Jonathan is the Clifford Shan Chair in Physical Education and the Director of the Center of Lifestyle Studies at Acadia University, which is in the very east of Canada in Wolfville, Nova Scotia. Jonathan has been part of the EIM Canada Advisory Board since its earliest days of inception and has served as the EIM National Center Director since May of 2016. Today, Jonathan will be speaking to us about his own experiences developing EIM in Canada, and more specifically in his province of Nova Scotia. Jonathan, thank you for taking the time to provide us all with this presentation. We are eager to learn more about your work in Canada. And with that, I will turn it over to you.
Great. Well, thank you very much, Mark. It's my pleasure to share our experience with the global network. So just to get a little presentation overview, I am going to be focusing today on our project that we did in one province of Canada, which is in my home province of Nova Scotia, because this was the first time that a whole province kind of embraced the EIM philosophy and attempted to integrate this into healthcare. So this serves as a great example for EIM in Canada. So I'll talk about some of the innovations that came out of that, or some of the results that we did out of a research project and an environmental scan, some of the key innovations that we had out of the project, and then other innovations that have kind of arisen from the group, and then there'll be time for question and answer. So as I said, the Exercises Medicine project in Nova Scotia was a multidisciplinary initiative. It was supported by the Nova Scotia Health Authority, which is the organization that manages all of medical care in Nova Scotia. It was endorsed by Doctors Nova Scotia, which is really important because the medical professionals basically contract services to the health authority. It was supported by the Lawson Foundation. They've supported a lot of my research over the years. And so they help to provide coordination support as well as workshop support. And there was a steering committee that was made up of people from each of those respective organizations. One of the key things with this is we had 3 different vice presidents from the Nova Scotia Health Authority on our steering committee, as well as the chief medical officer for Nova Scotia, as well as the managers for a few of the provincial programs. So Cancer Care Nova Scotia was involved, as well as the Diabetes Care Program of Nova Scotia, as well as Dalhousie Medicine, which runs most of the continuing medical education in our province, as well as a few colleagues of mine from Acadia University. So the Exercises Medicine Nova Scotia project was a 3-phase pilot implementation. It was in collaboration with Exercises Medicine Canada as we used the materials, we used the workshop that was nationally accredited and that we've delivered all the way across the country, but we focused an effort here to do more workshop training in the province. As I said, it was supported by the Nova Scotia Health Authority, and they supported this by providing coordination support as well as communications, notifications of website registration for the workshops and things like that. And it was endorsed by Doctors Nova Scotia, which really helped to get the physicians out to the workshops. So the first phase was a provincial survey, which was an environmental scan that was completed by over 600 healthcare professionals across a range of professions. Then we learned some information about that. Then we decided to do an implementation where we did our workshop training. We had over 55 physicians attend the workshops and over 180 allied healthcare professionals in 9 formal workshops, but we also did, and I did, probably 10 other education sessions, such as grand rounds, invited presentations, and things like that, that also delivered the message to probably over an additional 500 healthcare professionals in Nova Scotia. Through all of these workshops and presentations, we distributed our Exercises Medicine Canada prescription pads and encouraged monitoring of our physical activity vital sign and prescription of exercise. Part of this project, we also wanted to link community resources to healthcare, and so we did 25 different meetings with community programs, identifying what resources they had available, what resources they needed, and how that could be integrated with healthcare for exercise, referral, and programming. And I'll share some of that information with you today. The goal of this whole pilot implementation was to get to the point where we could make recommendations of how to integrate this into standard care. It is a priority of the Nova Scotia Health Authority to have exercise integrated into healthcare delivery. And so this was important in this project. And so it's now led to, as I'll show, stronger links for continuing medical education, as well as links for programs, professionals, and resources. This is, as we've all probably experienced, changing practice is difficult because it's not only the evidence. We all know that the evidence is very strong for physical activity, as well as the exercise prescription in healthcare, but it's between the tension between the evidence and the context. And how do you actually change practice on the ground? It's kind of like trying to change the engines of a plane while it's in flight. And that is the challenge. And so I'll hope to share some of that experience that we had here. To give you kind of the key findings that we had from our research, one was that many primary care providers, such as physicians, nurses, and many dietitians, had low confidence or knowledge for physical activity counseling and exercise prescription, and had a low frequency in practice at baseline. One thing that we found, though, is that providing education or training increased confidence by typically 25 to 30%. It increased physical activity counseling and exercise prescription practices in clinical care, and also reduced barriers. The number one barrier that was identified by healthcare professionals was actually patients' interest in doing physical activity. So simply by doing the workshops, it reduces the barriers for healthcare providers because they understand more what's needed to address patient barriers. And so that reduced that barrier of patients not being interested by 30%, and we really didn't do anything with patients. We just did it with healthcare professionals. The other kind of key finding on education and training was that almost 80% of healthcare providers desired more training in this area. So there is quite an interest in getting more literate on how to counsel patients on physical activity and how to prescribe it in practice. One of the key findings that we had was that the second barriers that healthcare providers identified was that having programs, facilities, and exercise professionals to refer to is really, really important, because most family docs, for example, do not want to do exercise prescription in a vacuum. They need the support to refer people to, especially if they have different chronic conditions. The other thing that was particularly identified by physicians was that there needs to be administrative and policy supports that make physical activity counseling and exercise prescription the easier option. For example, many Family doctors did not know that there was a lifestyle billing code in Nova Scotia that they could use to do exercise prescription. And many nurses, for example, identified a major barrier of not having time off to actually take physical activity counseling workshops and upgrading medical education as a barrier to them being able to do this in practice. So some of the details on those findings. Here is the results of our environmental scan survey that was filled out by over 600 healthcare professionals, identifying their confidence level to perform different physical activity counseling and exercise prescription details. And it's separated in light blue for those who have had no previous training to those in the dark blue having some previous training. And as you can see, that there's a big difference in confidence if somebody has had some previous training, and that confidence levels are much lower in their patients to maintain physical activity, as well as in healthcare providers to provide advice to individuals with special considerations. So when patients' comorbidities get more complex, it gets more challenging for the healthcare provider to prescribe that. And we know that for somebody to do something confidently, they need to be at least at a 70% level. So therefore, they need the training in order to be able to do this. Otherwise, they just won't do it in practice. This was some of our data of what things they did in practice. So whether they included physical activity into sessions, about 40 to 50% of providers were saying that they talked about physical activity. Some of about half said that they assessed physical activity level. Less assessed readiness. Many recommend physical activity, but again, we have to be careful of general recommendations to, you should be more active, which basically is not actionable and basically falls on deaf ears. The prescription of physical activity, which is something that is actionable, is actually pretty low. Only about 12% of physicians do it on a regular basis, 13% of nurses. Our exercise professionals, such as kinesiologists, physiotherapists, and sport chiropractors, etc., prescribe exercise regularly, but even they do not refer on to other healthcare professionals that often. And that's because in Nova Scotia, we identified that there aren't too many exercise professionals that are available to receive those referrals, especially covered under medical care or insurance programs. This was a major finding of the results of our workshops, which shows the change in confidence as a result of our workshop. And one of the criticisms that people have about continuing medical education workshops on physical activity, people say, well, only the people that are interested in physical activity show up. Where we subdivided our physicians into 3 groups: those who are at low confidence level initially, which is the green bars; those who are at a medium confidence level, which is the light blue bars; and then those who are at a high confidence level to come to the workshops. The first finding was that we had about an equal distribution. We had about 23 physicians in the low group, about 20 in the middle group, and about 21 in the high confidence group. But as a result of the workshop, they all significantly increased their confidence level. Obviously, the relative amounts are much greater for those who are at low confidence level initially, but even the ones at high confidence level in the blue significantly improved their ability to provide physical activity information, answer questions, make appropriate referrals, and overall self-confidence. So that's an important aspect when people ask you about providing workshop and continuing medical education. This translated to changes in practice. So again, separating those physician groups into low confidence, medium confidence, and high confidence, you can see that the percentage of physicians that provide prescriptions in practice, whether, in the top group there, less than 10% of the time was the majority of the physicians initially. And then that shifted up so that more of them were providing more prescriptions more often. And even in the middle group, the medium confidence group, you can see it shift up. And even in the high confidence group, you can see that the percentage of them that are providing prescriptions in most appointments shifts up quite dramatically. So from less than 20% most of the time initially to more than 75% of them were providing prescriptions most of the time after workshop training. We also asked healthcare providers what can help you to be more effective with physical activity counseling. And again, this number one thing was patient expectations and readiness. So, you know, my job would be a whole lot easier if patients wanted to do it more, which is something that we address in our workshops. And then the next level was this availability of personal comfort and confidence, which is a result of the workshops. But the other green things was availability of exercise professionals, community programs, and facilities to refer to. So that was the big thing that we identified, is that they don't want to do it in a vacuum. They need help to do it. And then we did this as well in an open-ended solicitation from a number of different workshops that we did and evaluations. And again, the same three things kind of come up: affordable community programs, availability of exercise professionals, as well as increased physical activity education and training. That's what the physicians identified. And the physicians also identified this improved billing structure, because many of them thought that it was, in a fee-for-service model, wasn't effective for them to do that, to prescribe exercise. So what were some of the innovations that resulted of our immersing in this provincial program to support physical activity promotion with healthcare? Well, we, distributed through the workshops, the prescription pad, and educated people on how to do it. And then we came across some examples. The model that we were working from was to do a collaborative care example where the physicians would provide brief referral or brief counseling and then referral to community programs, community walking tracks, etc. We actually piloted in 2 locations where an exercise professional was embedded right within the collaborative primary care team. So the physicians could make referrals right to the certified exercise physiologist to do counseling, screening, prescription monitoring, and we had 2 locations where that occurred. And in that example, the exercise physiologist could also then run programs in the community, as well as make referral to other programs in the community, such as this one, which was a walk and roll program for frail elderly individuals that was led by a physiotherapist, an occupational therapist, and a kinesiologist. And we had a number of these programs in several communities in Nova Scotia that healthcare providers could make referrals to. So that example that I provided there, we did through the Acadia Center of Lifestyle Studies, where we had an exercise physiologist provide services in a collaborative practice, health practice that had 10 family physicians, a psychiatrist, nurse practitioner, counseling therapist, dietitian, and other physiotherapists. And they provided appointments 2 days a week, essentially. And then also ran an active aging community cardiac rehab programs. And it was very effective to link the primary health care to community wellness through that exercise physiologist. The number of referrals that we received, this is one of these administrative issues that was identified, was that pre-EMR, so before the exercise physiologist was identified on the EMR, we would get, 10, 12 referrals a month. And then once we got on the EMR, where the exercise physiologist was right there, the physician could, just make a quick note on the computer to refer them, we were getting, 40 referrals a month from that. And so an extra, 20 or 25 referrals a month simply by being on the EMR. We did a chart review, and we now have over 700 visits that have been seen by the exercise physiologist. But the results are pretty similar to this, which is, 75% of the visits include both physical activity counseling and exercise prescription, Only about 20% of them include fitness assessment as part of that. About 50% of patients are given a home program, 20% are referred to community exercise programs, some are referred to community fitness centers or other fitness centers, and about 30% return for follow-up physical activity counseling and exercise management. For the small percentage that did fitness assessment as part of the visits, we can see that we get objective improvements in not only aerobic physical activity. Distance exercise basically goes from none at baseline to, on average, 3 sessions a week. Sedentary behavior goes down. Confidence to exercise almost triples, which is the biggest effect of having that physical activity counseling appointment with an exercise professional. The functional measures, especially for older adults who tended to be age 55 to 75, tended to be sedentary. Their functional independence scores in a sit-to-stand test and balance improved by almost 25% or more. The key thing of having that exercise professional in the counseling was connection to other programs in the province where people could be supported to be active. So in Nova Scotia, we have a program called Nova Scotia Connect, which is an online database of all the physical activity and recreation programs in the province. So part of our workshops, we're educating the healthcare professionals that there was this database out there that they could refer their patients to look up any physical activity program in the province. Within our Nova Scotia Health Authority, we also had these things called community health teams, which are really focused on preventive health. And they are largely in Metro, which is our Halifax, our biggest city in Nova Scotia, has a population of about 450,000. And there's 5 of these community health teams that promote physical activity, diet, psychological wellness, and social wellness. And they had many wellness programs that could address things. The chronic disease exercise programs, we have several of them in the province. Your Way to Wellness, For the Health of It. In Motion, which is a community cardiac rehab program. There's these aging programs called Active for Life and Active Aging, Walk and Roll, as well as Access, which is a community cancer exercise program. There are some facilities to refer to. The gold standard are medical fitness facilities that, there's examples of which in different countries in the world, but in Canada, there's only 5 of them, and 3 of them are in Winnipeg, which is in central Canada. There's a couple rec centers in Nova Scotia that we collaborated with. One of them was in Truro, and they set up training to be able to offer community cardiac rehab programs as well as community cancer exercise programs that started receiving referrals as a result of our Exercises Medicine project. As I mentioned, the community health programs, community health teams, they had a number of physical activity programs, low intensity exercise, Move to Improve, etc., weight management and physical activity. The low intensity programs were built on a cardiac rehab model where they did 10 weeks that for people with chronic conditions, and they did, there was education involved, they were in community locations and people could self-refer. They collected data on these and they increased the number or the percentage of people that could meet guidelines. They increased the percentage of people that met a blood pressure target and maintained improvements in walking distance assessed by a 6-minute walk test. So these community programs shown to be effective in this pilot that we were doing. This Move to Improve program was a collaboration with the community health team as well as the Canada Game Centre, which is a local fitness center. So again, the 10-week low-intensity exercise program and community cardiac rehab program was based on this HeartWise model that trains local fitness professionals to be able to deliver cardiac rehab type programming, which would be similar to the EIM credential training. It was an 8-hour workshop, and they learned about contraindications for exercise for older adults and those with chronic disease, and it increased the capacity to offer these kinds of programs in communities. and it's shown to be very effective. The programs are currently fully subscribed and are being expanded to a number of fitness centers across the province. Another one that was a result of our workshops, we did 9 workshops for exercise as medicine in the province, and we did 2 specifically on cancer and exercise, which then trained our local oncologists about the benefits of exercise as well as the need for exercise before treatment, during treatment, and after treatment. We then followed that up with this ACSS program, which was the Activating Cancer Communities Through an Exercise Strategy. It started in another province of Canada in Alberta, and then we had the leaders of that program come to Nova Scotia and train local healthcare providers as well as fitness professionals on how to deliver the exercise program. And then there was a grant that was obtained through kind of like a Dragon's Den, $100,000 grant to run the exercise cancer program at the hospital site in Halifax, as well as these 2 community centers in Canada, at the Canada Game Centre, as well as Truro. And we expected that it would take 6 to 8 months to get the number of referrals. Over 100, where our target was 120 referrals to the program, and we filled that referral target within the first month. We had 120 referrals in the first month to those exercise programs. So the key finding from that was that to have these successful exercise programs in communities, it's important to have a critical dose of exposure to exercise with leaders. You don't need a ton of facility or equipment. You can do it in communities, in a church basement. You can do it at a local health center. You do need an exercise leader, such as a kinesiologist, a certified exercise physiologist is optimal, or a physiotherapist. But you can also have healthcare professionals and other fitness professionals leading exercises who have gotten a little bit of training. The key thing that we find is that these exercise programs, when cancer groups get together, or people with diabetes get together, or people with heart disease get together, they support each other, and that social, psychological support by like-minded individuals is really important. And that the training that we did with Exercise as Medicine through the workshops was really important because it provided those motivated champions of healthcare providers, like a doc in a community that makes referrals to these programs. In Truro, this one, we trained a group of physicians that made referrals to the local rec center there. And the manager of the rec center basically said that they received over 900 referrals from the local physicians groups over a 1.5-year span. And almost 30% of those referrals ended up signing up for memberships at that rec center. So they got over 300 new members that had previous cardiac disease, etc., to this rec center as a result of the workshops and training that we did and educating the healthcare professionals to do it. In Truro, in in conjunction with that rec center, we also did a walk-in clinic instead of a walk-in clinic when you're sick. In this picture here, the local doc there, combined with the manager of the community center, they set up a local walking program with physicians every Saturday morning. And within weeks, they had over 50 or 60 people from the community going every Saturday morning to have a walk with their doc. And so now that practice, they have 5 physicians that rotate. They each take a Saturday morning. And some days they get up to 100 people going to this Walk with a Doc program. They've now partnered with a local Sobeys grocery store, and a dietitian comes and does a healthy eating plan once a month, and that's when they get over 100 people come, because they get free lunch or free breakfast after the walk. And it's changed that community, and then they get more and more referrals to that rec center. One of the other things that we did with our provincial exercise program We also integrated our CEP with the local school, because the best way to prevent disease is to start early with kids. And we set up a exercise program before school 3 days a week. And it really put exercise as medicine kind of on the map, because it was run through an exercise as medicine initiative. And the local healthcare professionals heard about it, as well as the local teachers and things started really supporting the program. So it became a neat little thing. So some of the primary recommendations that we had out of our project was that to increase education for healthcare professionals. Most medical professionals do not get that training as part of their medical training, and that the evidence they said was a valuable component to help them change their practice. We also made recommendations to review and modify policies, procedures, and programs to make physical activity counseling and exercise prescription the easier choice. As a result of that project, or those recommendations, the Nova Scotia Health Authority is now including in their standardized EMR that is being distributed throughout the province a note for a physical activity vital sign. So there's blood pressure, heart rate, temperature, breathing rate, and physical activity level is now being rolled out across the province as a result of the Exercise as Medicine initiative that we did. As well, they're also reviewing their billing procedures to make not only the physicians be able to bill for physical activity counseling, but also the insurance to cover people who seek out exercise professional services and do cancer exercise and cardiac rehab. The other recommendation was bridging the gap from healthcare to community and making sure that the healthcare community knew about the community programs, and making sure that the community programs had the lens to understand that most of their older adults have chronic conditions that they need to be aware of, and that to run programs that could cater to that. So the specifics on these things, the healthcare professionals being offered regular training. The key thing is around motivational counseling to assess, and also assessing patient safety and screening. We've had several meetings with the Dalhousie continuing medical education, as well as their medical curriculum, to be integrated into the curriculum. So I now am giving presentations in their medical family medicine program, as well as we're developing a workshop for their continuing medical education program. And we're now working with community health to do a exercise as medicine workshop for the public, so that they understand that moving is safe and one of the most effective ways to improve your health. Many of the public still think that exercise is somehow dangerous, and so that has resulted in a community public health initiative, the Exercise as Medicine initiative through that. The healthcare professionals that we surveyed basically are very interested. 82% of respondents wanted further training, and they want everything. They want half-day workshop, full-day workshop, a webinar. They wanted clinical rounds. They wanted provider fact sheets, patient fact sheets, so a range. So everybody wants something different. So as long as you're trying to develop a number of resources to support it, then that will get to somebody. The key thing is, which conditions. Most professionals are aware of the benefits of exercise for hypertension, obesity, mental health, but many of them identified that they're least comfortable prescribing or recommending exercise in cancer and respiratory conditions. Even osteoporosis and osteoarthritis were a little bit more challenging. So providing fact sheets and information for those groups is important. The billing structure, having the physical activity vital sign in the EMR, as I've shown there, reviewing the billing structures, and then we're starting the ball rolling to get medical coverage for exercise therapy for conditions beyond traditional cardiac rehab. The evidence is there for diabetes rehab, obesity rehab, cancer, falls prevention, and musculoskeletal prehab. One of the things that's recently happened in Nova Scotia is that they've developed through a pilot project a patient support platform that's integrating with an EMR in the osteoarthritis and knee hip program in the province, so that patients will then get their exercise programs linked to their EMR as well. And this is a multi-million-dollar project that's just being released actually next week. So they'll get prescribed their exercises through their patient platform as well. The enhanced community supports, and again, bridging this access gap from healthcare to community is really important. So educating the healthcare community about programs, and then educating community recreation programs that they need to hire exercise physiologists to run exercise programs that cater to people with chronic disease. Because this is what we see as the #1 barrier for physical activity among Canadian older adults. It's not lack of motivation or lack of energy or time or anything. It's their health condition. Their fears about their health condition is the #1 reason why older adults in Canada do not partake in exercise. And so you need to address that with exercise professionals running community exercise programs that know what they're doing and know how to modify exercise for somebody with Parkinson's, somebody with osteoporosis, somebody with a previous heart condition. So some of the further things that we've recommended and that were successful with our provincial program here is that we integrated this approach with the community or the provincial initiative for physical activity. So the timing was right for this initiative because there was a national strategy for physical activity that was actually started through the Exercises Medicine Canada initiative. I actually spoke to the federal government and the Senate Standing Committee on Obesity and made recommendations around a physical activity, a national physical activity strategy, which was then launched in the fall of 2018, which then forced each province to develop their own physical activity strategies. And so I was involved because of my work with Exercises Medicine with the Chief Medical Officer, the Department of Health, the Department of Community Cultures and Heritage to include information about healthcare, et cetera, in the Let's Get Moving provincial strategy. And they even had words in there. Healthcare providers are important influencers and can help increase awareness and access to community-based programming. And they made recommendations for increased training on physical activity for healthcare providers, as well as strengthening links to community programs. And it was right there in the provincial strategy. And so I've subsequently been asked to numerous high-level provincial meetings to recommend strategies in the workplace for an exercises medicine strategy in the workplace, in education, as well as healthcare, and linking exercises medicine with community exercise programming. One example of this is also in Alberta. They developed an offshoot of the exercises medicine program, which was Prescription to Get Active. And this is where they tried to engage healthcare providers to write prescriptions to local fitness facilities for generally healthy individuals. And the results showed that 73% of participants that received getting a prescription from their doctor reported increasing their physical activity. And the stats from that program in 2017 showed that prescriptions written were quite high. That resulted in almost 4,500 additional visits to rec centers in the province, which we're now rolling out in Nova Scotia, a Prescription to Get Active, and nationally it's now rolling out in partnership with Exercises Medicine. And we're actually going to be next month going to Ottawa, the capital, to lobby senators and members of parliament to roll out Prescription to Get Active and Exercises Medicine nationally. We're asking for $5 million to do it, and there's rumors that our Prime Minister may be in attendance in this meeting. So in summary, we learned through this project that healthcare has an important role to address physical inactivity. We need a multi-factored and layered approach. We need to promote physical activity counseling and exercise referral in clinical care and provide resources to do so. But we also need to address system factors such as education, baseline education, and administrative barriers, and that you need to marry that with practical implementation strategies that are sustainable, meaning building collaborative practice approaches that link healthcare professionals to community resources and make those community resources inclusive for those with chronic disease and accessible in communities, so that it's not just going to a fitness center, but it's community walking programs in recreation, in schools, walk with a doc, you know, all that stuff. You need to do the whole shot in order to make it successful. And many people think success is a straight line, but really this was a lot of challenge, a lot of up and down and working out barriers. But we think that the provincial program here was a model for the rest of Canada that now Canada is trying to embody and implement as well. So thank you for your attention, and I'm willing to take questions. I know that there were some questions there on this, so we can go.
All right, Jonathan, thank you so much. That was fantastic, and wow, a plethora of information to digest. I think I'll have to watch that video a few times over to refresh with all the things. So we do have one question from the chat board. The question is, I would like to ask about the motivation for general practitioners to prescribe exercise. Are there any audit tools, systems, or mechanisms used to encourage GPs to prescribe physical activity treatment in fee-for-service model health systems?
You know, this is a great question, and it's really is, it came up a number of times in our discussions. You know, how do you incent GPs to want to prescribe exercise as part of their model? So there was two things that were discussed. One was, for example, in Nova Scotia, there is a billing code, the lifestyle billing code. So I'll give you an example of how you can disincent of what happened when they first rolled it out. So the lifestyle billing code was launched in 2015 or 2016. GPs kind of got on board and they started prescribing the exercise and using the lifestyle billing code. But then the group, the regulatory body that regulates the billing structures and the billing of in fee-for-service did audits on the use of this code. And they audited many physicians, some of which the range was some people would use it once a year, and the maximum was one physician used the lifestyle billing code to the tune of $90,000 of billing in 1 year. And in the province, the auditors went out and said, you need to provide evidence that you prescribed exercise to these people and that they followed it up. And if they weren't able to show that they entered it into their medical record or prescribed, had a photocopy of the prescription that they gave them, then they were asked to give back money. And I talked to 3 physicians that were asked to give back between $5,000 and $15,000 in billing because they couldn't provide adequate evidence for their exercise prescriptions. So there's an example of how not to do it, which is to audit them after the fact, after they start adopting the technique that you actually want them to do. And then there was examples, and then, well, how do we do it better? And one was to subdivide the billing code, which was the lifestyle billing code could be used for smoking cessation, diet, physical activity, etc. So to subcategorize the code, so it was like lifestyle billing code 1.2.1 would be physical activity, 0.2 would be smoking cessation, 0.3 would be dietary, so that every time you use the code, you could show that you were using it for physical activity prescription. So then that would justify the use of the code. And then also to link it to the EMR where you could actually track their physical activity vital sign. So that would also be evidence for use of the billing code. So if you registered their physical activity vital sign was 90 minutes and you used the billing code lifestyle 1.1.2, then those two things linked together was justification for the billing. And then if you track that 3 months later and use the billing code again and track their physical activity vital sign, then it showed that they could change. And the evidence from Kaiser Permanente in California shows that when people do use the EMR to track physical activity, it does change clinical outcomes. And so then by integrating it into the EMR, you can then track it relative to their blood pressure, their body weight, their A1C levels, and things like that. So that's what they're moving towards in the province, is being able to link the EMR stuff to their clinical outcomes. And we're probably 5 years away for that getting rolled out. But that's what was discussed through the project, is being able to do that. The other thing that was identified was this incentive system. And so, for example, in the UK, they tried this where they incented GPs to have better outcomes for their patients. Basically saying that if you take care of their diet and physical activity and your patients do better, then you get paid more. And what happened was it backfired, because over time, GPs started figuring out that if they had a healthier patients in their practice, they would get paid more. So therefore, they stopped taking on more unhealthy patients, or their patients that were unhealthy and complex comorbidities. So that's not a way to do it. One way to do it, though, that has been discussed in Nova Scotia is to provide, and they do this actually in Alberta and Canada, where they provide bonuses on the billing in their lifestyle billing code if you actually talk about physical activity. So they give a $5 bonus rider because they know that talking about lifestyle takes more time. So that was the criticism that many GPs would say, is that if I talk about lifestyle, it takes way more time than prescribing medicine. So pay me more money to do it. So that's what they've done, and that's something that they're entertaining here in the next round of billing in Nova Scotia, is to give a $5 increment for the lifestyle billing code. So you actually get paid more money to talk about lifestyle than you do to prescribe a drug, because prescribing the drug is faster. The last thing that I would mention in that regard is having those collaborative practice models in place. So one of the barriers that physicians identified is that they didn't want to do it in a vacuum. So how can you incent and encourage GPs to prescribe physical activity as a treatment? Is you have nurse practitioners and exercise professionals in their collaborative practice that can then do the follow-up counseling. So the GP does the initial billing and says, you need to do more exercise, you should do 30 minutes times 3 times a week, and then refer on to their nurse practitioner or their exercise professional in their collaborative practice to do more of the counseling work so that the GP doesn't have to do that work. That was the other big comment that we had, was that they don't want to spend 15 minutes doing the counseling because they're ill prepared to do it, and they're better prepared to do other things. So why not have their nurse or their dietitian or their exercise professional actually talk about those key things? So that's the other way to incent them, is that more GPs were willing to do it if they knew that they had support, and that they would get shadow billing for the nurse to then see that patient for a 15 or a 30-minute appointment to follow up on their referral for physical activity counseling.
All right, thank you, Jonathan, for that very detailed response. I've unmuted everybody in case there's any other questions. Just give everyone a second to Any other comments? All right, well, Jonathan, I have one final question then.
Sure.
And I think so Robin's got a question here for us. If the physician spends an extra 5 minutes doing physical activity counseling, either all appointments run longer or that counseling replaces something else within the visit. How do you handle that in your work, or how have you seen it handled?
Yeah, again, that is the very real that physicians will say. So two things to that. One is, in the workshops, we talk to the physicians saying that using a motivational counseling approach, you spend a little bit more time investing in your patient's health. And that's how we frame it. You're spending 5 extra minutes to invest in that patient's health, because in the long term, investment pays dividends to address all their other health conditions. And so that's one thing, to get them to understand why to do it. That's the first thing. But then you need to address the administrative thing of, yeah, they're 5 minutes behind now. So two things. One is, instead of booking 10-minute appointments or 8-minute appointments that many physicians book, is that when they think that their patient is going to benefit from having more lifestyle counseling type approach, is actually to book that as a 15-minute appointment, and they can bill for that. They can bill that extra 5 minutes. There's, in our billing codes, there's other general office visit billing codes that they can use to get that extra 5 minutes. As well, there was one creative approach that one physician did, was he booked his patients that he thought would benefit from lifestyle counseling in 4 15-minute visits at the local community rec center. And he did those 15 minutes walking around a track. So that was where he took the walk with the doc to another level. And he said that it totally changed his visits and turned them into health visits as opposed to illness visits. And he said that in the long term, those patients did better and he didn't see them as much. So, so there's two things there. One is to have your physicians try and book that extra time. You can't do anything about the fact that you spend the extra 5 minutes and now you're behind, other than having to shorten your lunch hour. But, you know, doing the extra billing, looking at your schedule ahead of time and seeing what patients might benefit from having more time and actually booking less visits, or or booking more time so you have less patients, and framing that as an investment in your patient's health, and hopefully that they'll do better over time. Because the evidence does show that when people do motivational counseling, that it does take a little bit more time, but it does show greater health benefits in 6 months and a year later. But it does take a lot of education. It's tough to change the engines of that plane in flight, let me tell you. Resistance to that until they see the benefits.
Well, Jonathan, that leads me to maybe a final wrap-up question. And one of the things I'm impressed with your work is that we know how hard it is to change things at a national level, especially when you have different states and provinces that have different levels of autonomy. So it's been kind of really interesting to see how things have developed in Canada, kind of at the provincial level, and even at that, how hard it's been. So yeah. The question is, you know, some of our partners from around the world are just getting started. So they're maybe where you were 5 years ago. Can you give some simple advice on that local versus national and easy steps to get started in terms of trying to build towards what you've done?
Yeah, it's a good point. And the one thing I've learned, though, is that, you know, exercise as medicine requires a top-down, bottom-up, and side-to-side approach. And I'll unpack that a little bit, in that the work that we've done in advocacy at the national level gave awareness to the message and gave credence and validation to the steps that we would take at a local level. because we talked to the Senate Standing Committee on Obesity, and because we talked to MPs, and because we had a national advisory council that was made up of the major health professions. So on our National Advisory Council, we have the College of Family Physicians, we have the Canadian Physiotherapy Association, the Canadian Chiropractic Association. So it's important to do that work to set up your national committee with some big names and some heavy hitters and some important people in government and things like that, because that gives you credibility. But then the changes that are made are really done at a local level. You can develop, your national workshop, which is what we did, and we rolled it out nationally. We had probably 30 different workshops across the country and trained 2,000 healthcare professionals across the country. But the changes that are really made are done locally around that workshop with the 20 physicians that came to that workshop that day, and with the local community that is around that group of 20 physicians. And so you need to talk to your physician down the street, with your local fitness center, with your local exercise professional, and build that network of referral, of support, and then you build from there. And so that's where that bottom-up approach is really important. And so our provincial program, and the way that things work in Canada, is that healthcare funding is determined federally but managed provincially. So the reason why we did it as a provincial program is because we were doing all this high-level work with Exercise as Medicine Canada, which was important because it opens doors and does all that stuff, but all the decisions that are made in healthcare are made at a provincial level because the provinces manage the budgets of healthcare. So we knew that we needed to get into the Nova Scotia Health Authority and the senior management of the Nova Scotia Health Authority, because they're the ones that are going to be making the budget decisions on this. And so that's where we're at now. We did a pilot project that emphasized community networks, these little communities of practice, and did little workshops and built that out, that then justified to the province that this is really important work because the patients in this collaborative practice are doing better because of the work that we've done at a local level. So now we're lobbying the province as a result of our pilot project to now invest money locally through the Nova Scotia Health Authority to pay for education, for billing, and for exercise professionals to support. So, to answer your question, is it does require all levels. I think start with setting up your national framework, figure out where the money and those important decisions are going to be made, include those people in your advisory council, and then start locally with the groundwork. If you're going to do a workshop, do it in a community, invite all the players in that community to come and build success there that you can build back up. Because that's where you're going to lobby your city to invest in community recreation that supports exercise as medicine. Your state or your province are going to be making decisions about how they're going to invest in collaborative practice and exercise as medicine, and you build it back up from there, which then links back up to your national work.
Wow, fantastic, Jonathan. Robin's wrote a message here just saying how much she appreciates the incredible work you've done, your leadership, and it was inspiring. This was a truly fantastic webinar. I had no idea, I don't think any of us, how much incredible work you've done, and I think there's a million little nuggets here for everyone to gain from. So from all of us at the Global Health Center, thank you so much for taking your time, and also thank everyone else for participating in this webinar, and we're going to share this with everyone and get the word out of your great work, Jonathan.
Thank you very much. Is my pleasure, and I thank EIM Global for supporting us. It's been successful in Canada, but it's also, we've had our challenges, and EIM Global has supported us and continuing to collaborate in that regard. So it's a pleasure to be part of an international network in this regard, because again, that lends credibility and credence to open doors and to do the national, provincial, and local work that we need to do, because we're linked to an international program. So thank you.
All right, and with that, we are going to conclude. Thank you, everyone, and we will be in touch later this summer with our third installment of the Global Health webinars. Have a great week.
Okay, cheers, everyone.
Bye, everyone.
Be in Orlando to see everybody. I'm actually going to be in Ottawa lobbying to the Prime Minister